Good morning, everyone. I hope you all have had a great conference so far, and that you all are able to bring home some information for your care teams and your centers to help improve the lives of those with this disease. My name is Sarah Fouché. I have been caring for patients with CF for about 11 years. I've worn a few different hats throughout my time, but my current role is the adult CF pharmacist at U of L Health in Louisville, Kentucky. I'm also the program coordinator there, and I've been in that role since 2019. So Julie and I, and I'll let her introduce herself in a little bit, but we'll be moderating the session titled Watch Your Step, Navigating CFTR Modulator Potholes. We have 4 amazing speakers we have no disclosures related to this presentation. We have 4 amazing speakers who will be presenting today, and we'll allow a few minutes at the end. We're going to have everybody present all at once and then have questions at the end. So that if you have any questions, we ask that you submit them via the app, or there are a couple microphones in the room. Just in case you do have questions and you want to ask them in the room, just make sure you do step up to the mic because we are being recorded this morning. So today we are addressing challenges that are associated with CFTR modulators. Specifically, we'll be exploring weight issues associated with ETI, identifying access issues within the CF community, and then discussing ways to overcome barriers and address adherence. And then we'll also be examining pre- and postnatal care in infants that are exposed to ETI. So without further ado, I'll bring up our first speaker, Denise. So Denise serves as the dedicated adult CF pharmacist at Stanford Hospital in California. Guessing it's.
Hi, everyone. My name is Denise, and today I'll hopefully be shedding light on weight loss, optimizing pharmacotherapy in patients with cystic fibrosis. I have nothing to disclose, and today I'm going to be going over paradigm shift in nutritional care for patients after highly effective modulator therapy, identify some risk factors for obesity, as well as go over some options for lifestyle modifications and options for pharmacological therapies for weight loss, and then go over some considerations for safety for GLP-1 agonists for patients with cystic fibrosis, and end with some cases to summarize. So with the advent of highly effective modulator therapies, we're seeing a paradigm shift in nutritional care with increasing weight in our patients, as well as reduced energy expenditure and changes in pancreatic, both exocrine and endocrine function. I'm sure you guys have all seen these graphs, but in both pediatric and adult patients, we're seeing a shift in BMI distribution, trending more towards higher number of patients with both obese and overweight categories in the green and light blue. So the risk factors for obesity have changed a bit from prior to modulator therapy versus post-modulator therapy. In prior to modulator therapy, you saw risk factors for obesity in patients with milder CFTR mutations, patients who were pancreatic sufficient, age over 46, or a lower socioeconomic status. In post-modulator therapy, we're seeing the shift towards higher rates of obesity in patients with CFTR mutations that are more severe on modulator therapy, as well as pancreatic insufficient patients. And the trend towards obesity is actually matched with the general population for patients with CF, and it's age matched, where the highest propensity for obesity is in the age band of 40 to 59 years old. Of note, though, for similar BMIs, patients with higher visceral adiposity correlated with more sugar intake, and that also correlated with more insulin resistance and higher blood glucoses. And another thing to note for social determinants of health is food insecurity. This may seem like a paradox, but it may be that in households that are food insecure, there is just more access to lower nutrient, higher calorie dense foods, and that may be contributing to obesity. In terms of comorbid conditions, I've listed a few here, and it may be that in our situation for the advent of highly effective modulator therapy, it may be something similar to patients with HIV, where they found a therapy that has been helping and patients are living longer and they're having more of these metabolic disease issues cropping up. Something of note is the non-alcoholic fatty liver disease. There was a study from Bayshore where they reviewed patients with cystic fibrosis, and they did find increases in hepatic steatosis in patients with CF with BMIs over 25. So just wanted to review some of these obesogenic medications. So as pharmacists, when we're doing profile review, we can look through patients where we're trying to help them lose weight and identify some medications that may be more obesogenic and provide recommendations for alternatives. Again, apologize for this busy slide, but wanted to provide it as a reference for you guys in terms of some options. In terms of treating patients with CF-related diabetes, the treatment of choice is insulin, but you are seeing in some guidelines now, the ISPAD in 2022, mentioning that in certain CF centers, we are starting to use some of these other agents, but more research is needed. In terms of lifestyle modifications, we're replacing the legacy diet, which is high sugar, high fat, high calories with more nutrient-rich diets, and encouraging exercise for weight loss. This would be 150 minutes of aerobic exercise 3 to 5 times per week, and then also introducing resistance training. And then the behavioral change management is something that is multidisciplinary, really encouraging the patient to have more mindfulness in terms of looking at what they're eating and also having more realistic goals and really having more cognitive behavioral therapy changes to help with this lifestyle modification in general. From the Endocrine Society for Pharmacological Management in Obesity, we're looking for a 3-month trial with a 5% sustained weight loss. And really for patients, we're targeting 2.5% weight loss in that first month because early weight loss is a good indicator of more long-term sustained weight loss. So when to initiate pharmacological therapy? If BMI is equal to or greater than 30, or if they have comorbid conditions with BMI equal to or greater than 27, you would want to start pharmacological therapy in addition to lifestyle modifications. So here's just a mechanism of action. It's a little bit fuzzy, but a lot of the medications used for weight loss are anorexic in signaling. So examples are phentermine, bupropion, and naltrexone. And in a separate category, at the kind of very bottom is the exenatide, liraglutide, or GLP-1 agonists. So those enhance glucagon secretion and increase insulin, and also help to decrease gastric emptying and enhance satiety. So a little bit more on phentermine. This is really more used for short-term use. It has anorexic effects, but these end up becoming patients become tolerant to it in a few weeks, and once they become tolerant to it, you would discontinue it. It is a tablet form, and it is scheduled. Patients with increased appetite may find benefit from this, and it is pretty cost-effective, but it is something that you would use only for short-term and would not be contraindicated for patients with history of seizure or cardiovascular disease. You would take it on an empty stomach and monitor for the cardiovascular effects of palpitations and heart rate. You can add to this topiramate. That does come in a combination pill, but this requires REMS for prescribing due to the teratogenic risks. So on top of all the side effects for phentermine, you'd also look out for kidney stone formation, and you'd look for drug-drug interactions with concomitant diuretics like hydrochlorothiazide and furosemide to monitor for hypokalemia. And if the patient is trying to start a ketogenic diet, then that may increase their risk of kidney stone formation. The topiramate will decrease the effectiveness of hormonal contraceptive at 300 milligram doses or more, so you would recommend a backup non-hormonal therapy. Another alternative is bupropion naltrexone combination. This may worsen anxiety and migraines for the bupropion component, so may not be useful in that patient category. It does come in tablets. It's also helpful, hopefully none of your patients are smoking, but if they are concomitantly smoking, this could help to quit smoking. And if they haven't started any therapies for depression, you could consider starting this therapy. If they're already on a therapy that for depression that's serotonergic-based medication and you can't really switch them to it, it may not be the best option. And because of the naltrexone component, it's contraindicated in patients taking opioids. So this one I just put in for completeness. Orlistat is used for weight loss. Its mechanism of action is reduced absorption of dietary fat. Unfortunately, how it does that is it inhibits the action of lipase, which is not really helpful for our patients with cystic fibrosis. So it'd be great if everyone just didn't use this medication for our patients with cystic fibrosis. So then going a little bit deeper into GLP-1 agonists, I'm using this as just a general umbrella term. Tirzepatide is actually a GIP-GLP-1 agonist combo. So the three options that are available for weight loss are semaglutide, liraglutide, and tirzepatide. So the major warning here I want to focus on is the history of pancreatitis or risk factors for that. So some risk factors would include patients who are drinking more than 3 drinks of alcohol per day, or if they have hypertriglyceridemia. This comes in an injectable form. Semaglutide actually comes in an oral tablet as well if the injectable form is not preferred. And this would be preferred for patients with diabetes with high ASCVD risk to lower their ASCVD risk. Contraindicated in patients with history of thyroid carcinoma, endocrine neoplasia, and also with large unresected gallstones. At Stanford, we do have pharmacists at the weight loss clinic and hepatology clinic, and we have started patients on GLP-1 agonists with gallstones under the guidance of the hepatologist. And any patients with history of gastroparesis or history of cardiac arrhythmias, this would also not be recommended. In terms of monitoring for worsening depression, if patients have psychological disorders or have uncontrolled depression, this wouldn't be recommended as it may increase risk of suicidal ideation. So under the guidance of a psychiatrist, if a patient is stable, you could consider starting a GLP-1 agonist. And then this can cause decreased gastric emptying. So for patients who are perioperative, this may increase your risk of aspiration perioperatively. So it's recommended to hold prior to surgeries for general anesthesia. So the recommendation is generally 7 days prior to the surgery. This may or may not be that useful if patients are really using this to control their blood sugars. But for the weight loss indication, it would be recommended to hold that. And so just a little bit more on patient education for GLP-1 agonists. It is stored in the refrigerator, although the pens that are actively used can be stored at room temperature, and contraception is recommended for female patients. If patients are starting family planning, I would recommend stopping this 2 months before family planning. And the major side effect for this is the GI side effect of nausea, vomiting, diarrhea, and constipation. So really to ensure patients are successful in their journey on the GLP-1 agonist and any titrations, you want to give them good counseling tips on how to start that. So when they're starting, you want them to start on eating smaller portioned meals slowly and without any distractions to really see if they're feeling the satiety effects of the medication. So starting with blander foods, smaller meals like soups or smoothies, and not those really greasy meals that would decrease gastric emptying and increase the risks of nausea and vomiting. So without any distractions, if they, let's say, eat a small meal, wait 20 minutes, and if they're still hungry, then go back and get seconds. But if not, then stop eating. And then with time, as their body adjusts, then they can start increasing their meal frequency or eating a little bit more to see how they do. In terms of signs and symptoms of pancreatitis, you're looking at right upper quadrant, abdominal, back pain, fever, and nausea and vomiting. There aren't really any markers that you can use. Like you can't really monitor lipase for this because when they're starting on GLP-1 agonists, their lipase may also increase as well. So it's really more just signs and symptoms for monitoring for pancreatitis. And then I know you're probably wondering, or the patients are wondering, but what about Ozempic face? Well, I got you there, girl. So really what you're worried about is weight loss that's too rapid, and that may increase the risks for that. So you're looking for starting low and going slow in terms of your titration. So again, with the GI side effects and side effects of increased rapid weight loss, you really want to make sure that you're titrating appropriately. So at our clinic, we see the patients, or at the GI and weight loss clinic, they see the patients every 2 weeks to see how they're doing, and then they do the titrations about every 4 weeks in terms of dosing. I included in, excuse me, I included in the app a guide of how we dose some of these medications, some of the monitoring parameters, as well as the titrations in the app. So if you wanted to look more closely at those. So just going into the patient case, this is a 41-year-old female with cystic fibrosis, genotype heterozygous for Delta 508, and she has a BMI of 36. She is on ETI and she is pending lung transplant. She is on 3 liters of oxygen due to chronic hypoxia, respiratory failure, and she does have obstructive sleep apnea for which she has a CPAP machine. She has chronic pain for which she is currently on opioids, and she does have pancreatic sufficiency, and she does not have diabetes or CF-related diabetes. She's already started pharmacotherapy and she's already tried and failed some options. So she started on phentermine, but she's noticed that the anorexic effects of it has diminished. So we stopped that medication. She's trialed bupropion, but noticed that her anxiety was worsening with this. And she's currently on topiramate 100 milligrams 3 times a day with a 15-pound weight loss. But in order to qualify for lung transplant candidacy, she needs to obtain a goal BMI of between 18 to 32 to become eligible. So the other options, bupropion and naltrexone, would be contraindicated because she's on opioids. So really all you're left with is GLP-1 agonists. So in this patient, just a show of hands, how many patients would consider starting a GLP-1 agonist on this patient? Yes, yes, or no? Yeah, so let's go into it a little bit more. So just kind of navigating the risks for pancreatitis on the far side of the slide, there's this helpful pictorial to indicate what the risks for pancreatitis is. So on the very far, I guess my right, but maybe it's your left, yeah. You can see that for patients where they have just complete distal obstruction and they have pancreatic insufficiency, their risk for pancreatitis is really low because there's just nothing flowing. And then on the very far right of that, on my side or left for you guys, for patients with complete CFTR function and there's no distal obstruction, their pancreatic acinar reserve is great and there's no inflammation there, then there's no risk of pancreatitis. So really what you're worried about is all these people in the middle where maybe they have some pancreatic sufficiency, but then their CFTR function isn't that great. So they're at the highest risk for underlying pancreatitis. And so here you're looking at maybe patients with milder CFTR function will have a higher risk for pancreatitis. And then adding onto this is where do the modulators fit onto this? So are you pushing your patient from pancreatic insufficiency to sufficiency and pushing them into this risk category for pancreatitis? Or are you pushing them further outside of this category of risk for pancreatitis? So it's probably patient dependent. There are some case studies where the highly effective modulator therapies increase risk of pancreatitis, and there's other case studies that show decrease in risk for pancreatitis. So it may be that you're pushing your patient between these categories for high or lower risk for pancreatitis. And then not all patients with the same phenotype or CFTR mutations have the same risks for pancreatitis, so there are also external factors. So some things to consider for pediatric patients in the blue side is other genetic modifiers, and then for adult patients, some lifestyle modifiers as well. So for example, ethanol, smoking, other drugs and toxins, or if patients have hypertriglyceridemia or anatomical abnormalities. So there was a paper from Parks looking at a case series of patients with cystic fibrosis and using GLP-1 agonists. And I wanted to highlight 2 patients in this case series. Both patients, F and G, were pancreatic sufficient. And of note, neither of these patients were on highly effective modulator therapy. So similar to our patient, they're pancreatic sufficient. For these patients, they actually didn't end up tolerating the GLP-1 agonist. They ended up stopping it because of nausea, vomiting. For all the patients in this case series, none of them actually developed acute pancreatitis, but the N is pretty low for 11 patients. So more studies would be needed to see if there is a risk for pancreatitis. And then also note, because these patients weren't on ETI, we don't really know how the modifier would have helped or not helped with pancreatitis. So yes, knowing these 2 factors, does that change anyone's thoughts on whether or not they'd want to start therapy on this patient? Anyone say yes? No? Okay. So back to our patient, we were very close to starting GLP-1 agonists on this patient because we were worried she wouldn't meet lung transplant candidacy. But she ended up actually meeting the goal and she ended up receiving the lung transplant. But we were in discussion with the weight loss clinic physician, Dr. Hauser, and we were trying to discuss ways of maybe starting this medication if, in fact, she wasn't able to reach her BMI goal to obtain lung transplant candidacy. So then for the second patient case, we have a 46-year-old male homozygous for 5 delta and is on ETI with BMI of 32. Past medical history includes pancreatic insufficiency on pancreatic enzymes. Patient has diabetes on insulin and linagliptin and is well controlled on venlafaxine for depression. He's newly started on lisinopril 10 milligrams daily for hypertension. We have some concerns for obstructive sleep apnea, so we referred him to a sleep study. And we also have concerns for hyperlipidemia, but he hasn't been able to get a fasting lipid panel. So for this patient, would you start them on pharmacological therapy for weight loss? How many patients, or how many people say yes? Or show of hands? Yeah, how many people say no? Okay, yeah, so he's indicated for pharmacological therapy for weight loss, given some of these comorbidities. And given the diabetes, your treatment of choice is likely the GLP-1 agonists. So for the GLP-1 agonist for patients with diabetes, we have seen that it helps with delayed gastric emptying, reducing postprandial hypo and hyperglycemia, and reduced insulin dosing and helping with weight loss. So for this patient, we ended up starting semaglutide and stopping the linagliptin. And in terms of options, we basically went with what insurance covers, but there are some differences between the different GLP-1 agonists. So between semaglutide, tirzepatide, and liraglutide, tirzepatide has the highest amount of weight loss potential. But in terms of the medication, it is the newest option. So there are cardiovascular studies still out there. We don't really know how much it helps with ASCVD risk. So if you're really looking for lowering ASCVD risk, then semaglutide has the most studied and has pretty good weight loss as well. So then that's the next option. And then liraglutide, dulaglutide have less weight loss potential. And then really second, third tier would be something like exenatide, as it has minimal weight loss potential, and it also doesn't really help with the ASCVD risk. I do have other slides on, if you're in California, what is covered and patient assistance programs for this. If you guys are interested, you can email me as well. For this patient, he has been progressing pretty well. After 2 months of therapy, he's lost 1 kilogram, and he's tolerated the medication without too many GI side effects. His blood glucose has been better controlled, and he's continuing to work on lifestyle modifications and medication therapy management. We are still waiting for that lipid panel, but for him, it would be important for us to probably start a statin and really controlling some of these other comorbidities as well. Okay, and this is just slides showing what's on the handouts. And then here, this is what we have for the metabolic dysfunction, for steatotic liver disease clinic, and the different titration schedules for each of these. And then I'd like to thank my colleagues at the Stanford Cystic Fibrosis Center, as well as the Digestive Health and Liver Clinic pharmacists, and our weight loss clinic physician, Dr. Hauser. Sorry, the questions will be at the end. Yeah.
Thank you, Denise, for that presentation. Now I'd like to introduce to you guys Nicole Lochner. She is a Specialty Operations Program Manager at Fairview Pharmacy Services, the affiliated pharmacy services provider for mHealth Fairview in Minnesota. Since March of 2014, Nicole has dedicated herself to various roles within specialty pharmacy, accumulating in her transition to the therapy management team at Fairview Specialty Pharmacy in November 2017. Here she discovered her passion for patient care, particularly in serving individuals with CF. In November of 2021, Nicole took on the role of the Cystic Fibrosis Navigator, pioneering a program that offers CF patients and clinics a single point of contact for their pharmacy needs across multiple Fairview locations. Today, she manages these innovative programs across different disease states. Nicole resides in Blaine, Minnesota with her husband and son, and enjoys downtime, in her downtime, reading, cruising, and cheering on her son in sports activities.
Good morning, everybody. So my name is Nicole Lochner, as we said. Today I'm going to talk about one of the most challenging aspects of being a pharmacy technician, and that's navigating the complexities of insurance to ensure patients receive their CFTR modulator medications. I have no relationships to disclose. Today, our objectives are going to be understanding the process of prior authorizations in order to receive CFTR modulators with the considerations that the clinic needs to take into account. Next, we'll talk about the navigating difficult insurance plan coverages. And then finally, exploring copay assistance programs for CFTR modulators. So first, we'll start out with prior authorizations and what should be considered when doing or prescribing a CFTR modulator. So there are several important considerations when completing a prior authorization for a CFTR modulator. First, the CFTR modulator must be prescribed for an indication included in the FDA-approved labeling or medically accepted indication. Next, the prescription must be age-appropriate following the FDA-approved guidelines. The patient's CFTR gene mutation must align with the FDA-approved labeling, and the CF mutation test must be FDA cleared. Additionally, the CFTR modulator should be prescribed by or in consultation with a pulmonologist or a CF specialist. The clinic team must address any potential drug interactions. This may involve discontinuation of medications, adjusting doses, or counseling the patient on the risk and benefit of taking a CFTR modulator alongside other treatments. The patient should have no known contraindications to the prescribed CFTR modulator. Baseline lab results as recommended by the FDA, such as liver function tests and pulmonary function tests, such as an FEV1, should be completed, particularly for patients that are old enough to undergo PFTs. In some cases, insurances may also require an eye exam, depending on the CFTR modulator and the patient's age. For prior authorization renewals, particularly state Medicaid programs, they will require evidence that the patient is benefiting from the therapy. This could include maintain or improve PFTs, enhance quality of life, or a reduction in hospitalizations. Next, we're going to move on to different types of insurances and ones particularly that create challenges for patients and clinics when trying to secure CFTR modulators. First, we're going to talk about Medicare Part D. So in 2024, there are 4 phases of pharmacy coverage that patients encounter. The deductible phase, the initial coverage phase, the coverage gap or donut hole phase, and then the catastrophic coverage phase. In 2024, the average deductible for Medicare patients is $545. Before patients meet deductible is met, patients must pay the full price of their prescriptions. Once the deductible is met, the patient moves into the initial coverage phase, where they pay 25% of the cost of the covered drugs until their total drug cost is reached at $5,030 in 2024. After that, they enter the coverage gap phase, where they continue to pay 25% of the total cost of the drug until they reach the out-of-pocket max of $8,000 in 2024. Once that's met, they enter the final phase, the catastrophic coverage phase, where they pay nothing for their Part D covered drugs for the rest of the year. It's important to note for patients with Medicare Part D, copay cards cannot be used. However, grants can be applied towards their out-of-pocket costs. Another way to help lower copays is to enroll patients in Medicaid as a secondary coverage, which can assist with those out-of-pocket expenses if they qualify. So Medicare Part D in 2025 is going to look very different for patients. There are very significant changes that are happening. Most notably, there will be a new $2,000 cap on out-of-pocket expenses for patients, which will include the deductible, the co-payments, and the co-insurance for covered drugs. This cap does not apply to their premiums or to drugs that aren't covered by the plan. Patients will also have the option to enroll in the Medicare prescription payment plan, which allows them to spread out their out-of-pocket costs over the year Enrollment must be done directly through the insurance company. However, the pharmacies, when running these claims, will receive notification that the patient would qualify for this program. Under the new system, patients will continue to pay 100% of their prescription drug costs until they meet their annual deductible of $590. After that, they enter the initial coverage phase, where they will pay 25% coinsurance for their covered Part D drugs. This phase lasts until the patient reaches the $2,000 out-of-pocket maximum. In 2025, the coverage gap, or the donut hole, will be eliminated. Once patients move past this initial coverage phase, they will enter the catastrophic phase, where they will pay nothing for their covered prescriptions for the remainder of the year. It is important to note that these changes may lead to an increase in premiums in 2025 for Medicare Part D patients. Now let's transition into discussing accumulator and maximizer plans. First, let's look at their similarities. These plans are designed by insurance companies to reduce financial strain for plans themselves and employer groups, particularly small employer groups who often choose these options. Accumulator and maximizer plans typically target high-cost specialty medications and do not disclose their formularies to patients or pharmacies. One of the key features of both plans is they prevent any copay cards or copay debit card dollars from counting towards their patient's deductible or out-of-pocket maximum. However, it is important to note that grants should count towards these costs. These plans are managed manually by the insurance companies, relying on reporting from the contracted pharmacy for claims and payment details in order to adjust phases of coverage. If something doesn't feel right, such as if a copay seems incorrect, it's always a good idea for the patient or the pharmacy to contact the insurance company to review the copays and confirm reported claims. Now let's talk about the differences in accumulator and maximizer plans. With accumulator plans, medication costs will count towards the patient's deductible or out-of-pocket maximum if the patient pays with their own funds. Enrollment in copay cards are not required. Once the insurance company receives reporting from the pharmacy, they will adjust or back down the patient's deductible and out-of-pocket maximum accordingly. On the other hand, with maximizer plans, medication costs never count towards the patient's deductible or out-of-pocket maximum if the patient pays for the medication themselves. Enrollment in copay cards are mandatory if one is available. These plans are structured to fully utilize the copay card's available funds throughout the year, which is why they are called maximizer plans. I want to stress again, if something doesn't seem right about the copay amounts, it is always a good idea to contact the insurance company for clarification. Before I move on from this topic, I do want to mention that there's legislation at the state level for 21 states and at the federal level to ban and or regulate these plans. Now let's move on to the ever popular topic of alternative funding programs, also called AFPs. Like accumulator and maximizer plan, AFPs are insurance-driven programs designed to reduce financial strain on the plans and employer groups typically chosen by small employer groups. AFPs involve a third-party for-profit vendor that works with insurance companies to exhaust all available options for securing high-cost medications. In most cases, these expensive drugs are completely excluded from the insurance formulary, and CFTR modulators are absolutely always on the formulary for not being included for AFPs. Patients are required to seek medication supplies directly from the manufacturer. If the patient is denied free assistance, the insurance plan will resume coverage and the patient will be placed back into a maximizer type program. Here are some of the common alternative funding programs that we see. So what are some challenges that we see when trying to get a patient on a CFTR modulator. First, the patient must personally enroll in the third-party AFP company. Neither the pharmacy nor the clinic can do this on their behalf. As a part of the enrollment process, the patients are required to provide financial information so the AFP can attempt to secure free medication from the manufacturer. Many patients feel uncomfortable sharing such sensitive information, especially with a third-party program, which naturally causes concern and caution. If the patient chooses not to enroll in the AFP, coverage for the CFTR modulator will be denied. Often the patients are unaware of this aspect of their insurance coverage until the CFTR modulator is prescribed. And the pharmacy receives a rejection due to having the AFP program. This rejection typically triggers the AFP to send out program details and requirements for obtaining medication approval. However, I have seen that not all of the programs do this. The process to gain approval is lengthy and requires close cooperation between the patient, the pharmacy, and the AFP. It's not a quick or easy process, and as multiple steps must be followed carefully for the patient, for all parties involved. One significant issue with AFPs is they often secure medications for patients through patient assistance programs or PAP programs. The programs designed for those who genuinely need financial help. This means that patients who should be covered by insurance are receiving medications through programs meant for those in dire need, potentially limiting access for patients who truly rely on these assistance programs. So how can we help assist patients who have AFP plans? First, it's crucial to be knowledgeable about the steps patients need to take to receive AFP approval for their CFTR modulator. Use that knowledge to guide patients through the process, explaining what an AFP is and why it's essential to follow the necessary steps. Encourage the patient to contact the AFP immediately to begin registration and provide all required documentation as quickly as possible. Sometimes it may even be helpful to initiate a three-way call and stay on the line until the patient is connected with the right person. From my experience, AFP staff lack the deep understanding of medications and the urgency in getting them to patients. If you or the clinic staff speak to an AFP representative, take the time to explain the medication's purpose and why speeding up the process is critical. Establish direct contacts, whether by phone or email, with AFP representatives can be extremely beneficial in expediting approvals. It is also important to not duplicate work within the clinic and the pharmacy. The AFP is responsible for handling free drug applications and copay assistance, so allow them to facilitate that. Once they determine that a patient is eligible for the patient assistance program, they will send the completed free drug application to the provider for signature. Consistency is key. Regular follow-up with both the patient and the AFP to ensure that the process moves forward. If a patient has poor experience trying to obtain their CFTR modulator, we always recommend they contact their HR department to discuss their concerns and frustrations with the AFP. At my pharmacy, we have a dedicated person who works with AFPs full-time, navigating the complexities of the system and guiding patients through the process. That would be my final recommendation for helping patients get through AFP programs. Now let's discuss a patient case. So we have a 32-year-old male with AFP insurance who has a history of non-adherence with his CFTR modulator. On February 9th, 2024, our pharmacy discovered that the patient's insurance on file was inactive. We contacted patient and obtained updated insurance information. At that time, patient was required to complete lab work and have a clinic visit before the prescription could be renewed. The patient was seen on February 12th and the clinic renewed his prescription. A prior authorization was initiated by the clinic liaison and was approved on February 14th. On the same day, an AFP representative made the first attempt to reach the patient to begin the enrollment process. From February 16th to April 22nd, the AFP and pharmacy team made 18 attempts through calls, messages, and text to get the patient to sign up and submit documents to the AFP in order to secure coverage for his CFTR modulator. On February 21st, the patient was reached by the pharmacy technician who explained what an AFP is and outlined the steps for enrollment. The patient expressed concerns about the process, stating he couldn't contact the AFP during his work hours, and the AFP wasn't available after his work hours. He also hesitated to share his financial information with them. By April 22nd, after continued outreach attempts, the AFP deemed the patient non-responsive and his case was closed. On May 2nd, the patient was admitted into the emergency room with bloody stools and worsening digestive issues, which occurred as a result of stopping his CFTR modulator due to the unresolved insurance issues. He was discharged on May 3rd, and upon discharge, the pharmacy and clinic staff worked with him to restart his medication. On May 6th, the patient finally provided the necessary information to the AFP to initiate the approval process. His medication was delivered to the from the pharmacy on May 9th. This case just highlights yet another barrier patients face when trying to access their CFTR modulator, especially when navigating through AFPs. Not only do patients require prior authorizations with AFP programs, but they also have to enroll in and provide additional documentation for the AFP to obtain coverage. For patients with a history of non-adherence, this process can be overwhelming, making it less likely they will follow through. As a result, this leads to increased risk of exacerbations and hospitalizations, as we saw in this case. And then my final topic for today is some copay assistance options that are available to CFTR modulators. First, let's talk about the Vertex copay card. This program offers up to $20,000 in annual assistance. However, it's not available for patients with government-funded insurance programs such as Medicaid, Medicare, TRICARE, VA services, and Indian Health Service plans. Additionally, it cannot be used for patients with taking a CFTR modulator that is not included in the labeled indications, such as those in therapeutic studies. To qualify, the patient's healthcare team must first sign them up for Vertex GPS. Vertex GPS stands for Vertex Guidance and Patient Support. And this is Vertex program to help cystic fibrosis patients who are prescribed CFTR modulators. They help with financial assistance and education. After that, the patient will receive an email to electronically consent to enroll. Once the consent is completed, the clinic staff can proceed with signing the patient up for the copay card. There is not a lot of information on the internet about the patient assistance program for Vertex GPS. It's really a case-by-case basis that Vertex GPS looks at. Patients must be enrolled in Vertex GPS. Patients must exhaust all other avenues of funding. Clinics can refer patients to the free drug program, but Vertex GPS will send patients the forms to fill out. Vertex GPS will deactivate a patient from the free drug program if they have not communicated with the patient within 90 days. That's very important to know, as some patients are on reduced dosing that causes them not to fill within that amount of time. And finally, these are the grants that I am aware of for patients. So let's see here. So we'll start with the Healthwell Foundation grant. It covers up to $15,000 in prescription medicine copays. To qualify, you must have a household income at or below 500% of the federal poverty level, must have a cystic fibrosis diagnosis. Patients must have some sort of health insurance that covers part of the cost and must receive treatment in the US. The assistance fund, to qualify, you have to have a household income at or below 700% of the federal poverty level, must be a US citizen and diagnosed with cystic fibrosis, prescribed an FDA-approved treatment for this disease, and have prescription coverage. Next is the Accessia Health Grant. You must have a household income at or below 550% of the federal poverty level, must be a US citizen, diagnosed with CF, prescribed an FDA-approved treatment for the disease, and have prescription coverage. And finally, the Patient Advocate Foundation Copay Relief Grant. This covers up to $9,500 in prescription medicine copays, must have a household income at or below 500% of the federal poverty level, must be a US citizen, diagnosed with CF, and have prescription coverage.
We will save questions for the end. Our next speaker is Jenna Faircloth. She's PharmD, is a clinical pharmacy specialist in pulmonary medicine at Texas Children's Hospital and Baylor College of Medicine Pediatric Cystic Fibrosis Center. She earned her undergrad in biological sciences at Louisiana State University and her doctorate of pharmacy from the University of Tennessee Health Science Center. She completed her PGY1 pharmacy practice residency at Vanderbilt University Medical Center and her PGY2 pediatric specialty residency at Monroe Carroll Jr. Children's Hospital in Vanderbilt.
Okay, good morning, everyone. Thank you so much for letting me join you this morning to discuss a very interesting topic that's been very relevant to our practice and something that we are still continuing to learn as more data becomes available about the utility of elexacaftor, tezacaftor, ivacaftor level monitoring in practice, as well as in the role and its utility for medication adherence. So today, I'll just be sharing with you some data that's available in our own personal center's experience. So just to begin, cystic fibrosis medication adherence has been reported as a range from 35% to 75%. However, this data is primarily with nebulized therapies and other symptomatic treatment therapies. It was expected to be higher, and we'll go through that data in just a second, with our oral CFTR modulator therapies. Over time, that we're in this post-ETI era, we're noticing in practice and over a decrease in compliance with prescribed airway clearance therapies, as well as a decrease in compliance with ETI. And this paper by Hansen and colleagues out of the Netherlands recently published medication adherence to CFTR modulators, a systematic review of the available literature. Some factors they found that were associated with CF medication adherence was age. There's some conflicting evidence with this, because one study found that the younger the patient, the more likely they are to be adherent to therapies, whereas in another study, older age was tended to correlate with adherence. So that one's more of a gray area. Mean possession ratio has been correlated with FEV1. And so your higher mean possession ratio, or medication possession ratio, excuse me, is correlated with higher FEV1s. And so another factor that's been evaluated is NPR and BMI, body mass index, and then time, as we'll talk about. So this is to speak to the time piece. So this is Hansen and colleagues graphic of reviewing either, so they pulled studies that looked at medication possession ratio or PDC, proportion of days covered, and the adherence rates with modulators with that. And they looked at it over time. And this particular figure is breaking it out into 12-month follow-up and 24-month follow-up. So over time, how these patients were adherent to their therapies. The purple dot, so in the graphic, the figure B on the right, ETI is purple, and then on the left, it is the teal dot. But the takeaway from this literature in this particular figure is just that the longer patients are on therapy, adherence tends to decrease over time. So as pharmacists, things that we think about are, are they getting their fills too early? Over time, are they getting stocked up on medications? There's different things that we need to be thinking about when we're looking at this data, but it tends to trend with multiple studies that over time, patients' NPR was decreasing, which would indicate a decrease in adherence. So medication adherence, we're all very familiar with this, but some reasons for medication adherence, concerns for medication side effects, acquisition, as we just heard so eloquently in the previous presentation, with the challenges that can be faced with acquiring medication. Also, lack of understanding, patient understanding. I know that in certain populations, especially where families are less understanding of the diagnosis or accepting of this diagnosis, resistant to start therapy to begin with, and then to stop it as soon as any type of negative adverse effect occurs. The overall therapy burden, lack of symptoms, mistrust, and then mental health, of course, can contribute to adherence. So adherence monitoring tools that are available, as just mentioned in the previous Hansen data, so NPR and PDC can be utilized. So overall refill data, there's our specialty pharmacies have reporting systems that relay this refill data to us. There's also manufacturing reporting systems. So looking at refill data and medication on supply on hand can be a useful tool, but we know that there are also factors that can contribute to that just because they have the medication on hand doesn't always relate to the patient actually taking it. There are different medication apps for dose tracking. MedAction Plan is one that we use in our center with to track doses. The patients will download the app and track their doses that way. But also therapeutic drug level monitoring, and this has been seen with several other therapies. We know anticoagulation, blood pressure medications that have correlated with been a way to follow adherence. So a little bit more about that, therapeutic drug level monitoring and medication adherence. So drug concentration levels in the blood or urine have been an acknowledged method to detect medication non-adherence. TDM provides the ability to assess adherence in an objective way, supports informed decision-making in a shared decision-making patient care partnership with their team, and really just leads to transparent conversations because we've got this objective data that is indicating in this patient what could be, whether they're detectable levels or they're not detectable levels of the medication. So switching over to now the potential role for ETI levels with therapeutic drug level monitoring. I want to first just introduce discuss the commercially available tezacaftor level monitoring. So National Jewish Hospital has, and it's titled TriCaftor Level, their lab. And so you are able to, it's a send out to their hospital. The level's drawn 2 to 4 hours post the morning dose. And this is, to my knowledge, the only CLIA certified lab able to obtain these levels at this point in time. Some things to think about as you're scheduling your patients for levels. You want to try to obtain that Monday through Thursday. It's just, the samples shouldn't be shipped on Fridays or weekends. So to prevent the sample sitting much longer than what's ideal, consider obtaining it Monday through Thursday. The lab is, again, 2 to 4 hours after the morning dose, and this relates to when the levels peak. And these are the recommendations from National Jewish for level monitoring. A lab form is also, this is their lab form that is completed and sent in addition along with the sample send out. So the reason for the 2 to 4 hour recommendation from National Jewish is based on the time to maximum concentration or peak for the medication. It is different. It's very important to note that it is different for all 3 components. So elexacaftor is 6 hours, estimated to be 6 hours to the Cmax, tezacaftor 3 hours to the Cmax, and ivacaftor 4 hours. And the reference ranges for these levels are listed below. So elexacaftor 7 to 11, tezacaftor 6 to 9.4, and ivacaftor 9.4 to, or 0.94 to 1.5. There's definitely some limitations we've noticed as we have in general with ETI at this point to be thinking about. So as you can tell with the last slide, the peak for each component is at a different point in time. So when is the ideal point to draw that to draw the level if you're going to draw a peak? Again, they suggest they recommend a level of 2 to 4 hours, but depending on that just makes it challenging to interpret for the other components. Also, there's interpatient variability in between the variable concentrations, and we've definitely seen this as we've implemented this in practice. And a variation in concentration time course. Trough concentrations now, based on some data that I'm about to review, trough concentrations have been correlated with AUC exposure. So this article from Vonk and colleagues out of the Netherlands as well evaluated, so just orienting you to the graphs, the left, the y-axis is the AUC, the x-axis is the trough or Cmin concentrations. And as you can see, there's a linear correlation between those levels for each of the 3 components. And so with this, what we can take away is that trough levels can be a good predictor of exposure for our patients when we're drawing those and considering implementing ETI levels. At the time in which my center implemented ETI levels in our practice, this data was not available yet. And so we implemented a process for adherence with our patients utilizing the National Jewish recommendations. And so I'll review that now. So at our center, we obtain ETI level at the 4 hour mark. This just works best with clinic appointments and also having one consistent time point. So as we are learning about our patients, to get closer to that elexacaftor peak. But as we're learning, we're trying to have a consistent time point in which we're having our patients obtain these levels. So we selected 4 hours. So for patients that we have concern for adherence, on their day of admission, first or second day, depending on what works out logistically for the time that they were admitted, we are obtaining an ETI level after the morning dose or after the Alexatez IVA dose if it were a patient that were taking that at night or later in the day, but 4 hours after that. And then 7 days into the admission, after we've can confirm that the medication has been taken, about a week into the admission, we'll draw our second level. And then when those levels result, we'll review these with the family and just identify any patient-specific barriers. As mentioned before, it just can lead to a transparent conversation of this is the data we have, and objectively just address it and really start the conversation to try to get to the bottom of some whatever is going on from a medication adherence with that patient alone. This is just a graphic that it was a resource made for our physicians and team to explain this process at our hospital. So entering in, so there's an electronic order that has to be entered, and then there is the paper form that I showed just a bit ago. And then just walking it through, the patient has to have that if they're on the outpatient side, or myself and one of the other pharmacists will review with the bedside nurse, giving them the paper order form, the time in which it needs to be drawn. And then again, if you're on the outpatient side drawing these levels, just consider sending these, or in general, try to consider sending these to National Jewish Monday through Thursday. It seems that there can be longer turnaround times whenever obviously there's a holiday, or if it's drawn later in the week. That's just what we've seen in our experience. But they say on the website, the National Jewish website for this, they report a 10 business day turnaround time. So I'm going to review one patient case in which we implemented ETI level monitoring for the purposes of adherence. So an 18-year-old female with cystic fibrosis, homozygous delta F508, with a history of multi-drug resistant Achromobacter and Pseudomonas, and also with CFRD. This patient was started on ETI therapy November 2019. At that time, she saw a tremendous response. Her FEV1 went from 35% to 61% within 2 months of initiating therapy, and she was able to sustain that for the first 2 years of therapy. And then we've just noticed over time her FEV1 is trending down, and with this and a few other factors, it raised a level of concern for adherence to the medication. So though her refill data was excellent, and she was reporting adherence to therapy, there were, based on what we were seeing with her clinical outcomes and the previous response that we had seen, and a history of compliance concerns in the past, we were beginning to get concerned that she was not taking her medication. So this is when we implemented ETI level monitoring. This is just an example of whenever you get the result back from National Jewish, what that result's going to look like. This is the format of that, and it's one of her levels. But reviewing her levels specifically, so the bottom is the top. So the top is the most recent. The bottom is the first level that we obtained. So in reviewing this, just wanted to share some takeaways that we've learned. So again, highlighting here, there's a variable turnaround time in receiving this. And so that's going to be, when we're having these conversations with our family about adherence, something you have to factor into when you're planning to have that conversation. It's not going to be able to be in a real time during the admission conversation. We're having these conversations when they come back to clinic after their admission, or their next clinic visit. But there is a variable kind of turnaround time. Some other things to notice with this patient. So her first, another reason why we had opted to go with peak levels for adherence when we were first implementing this process. So we obtained a trough on her first level, and because of her ivacaftor was below the level of detection, and the other levels seemed to be on the lower side compared to the reference range, as I mentioned before, were much higher than that. We had switched to peak levels. So this right here, this level right here on May 2nd. So this was her on admission level. And so as you can see, tezacaftor was below the limit of detection, elexacaftor was below the limit of detection. A little over a week into the admission, we repeated the levels, and it flipped. It's really interesting, this, but so we were able to, she did have detectable levels of tezacaftor and elexacaftor, but our ivacaftor was below the level of detection, even though she was on full dose. And we just continue to trend these levels over time, but it's given us a, like, for example, here with 2 completely undetectable levels, we know that there's it opened up the opportunity for us to have a conversation with her, to talk to her a little bit more about her adherence. And she seems to have been a little bit more open and honest since this time, about her adherence, and there are many reasons for that, but I think that this has helped contribute and help us understand what's going on. And so so these are some just additional levels. So another takeaway that we've learned for her specifically is that she does not necessarily correlate with those, with the levels provided by National Jewish. So some inconsistent adherence, but at least trended up with having detectable levels. And so, and overall appears to be more compliant with her therapy. So this, so just in conclusion, some takeaways of how we've been able to implement this into our ETI level monitoring for adherence. It's really just led to having that shared decision-making, informed decision-making in an objective way to discuss with your patients their medication adherence. And there's still much to be learned about how we can incorporate this into our practice, but it can be a helpful tool and to start those conversations. And then going forward, we do plan to adapt our current process to incorporate more trough level monitoring now that there's more data available about strongly supporting the use of that. And then even the variable levels we've observed that trough will be a more consistent way to monitor this for this patient. But thank you for your time, and I'll be happy to take any questions at the end.
All right. Next up, I'm going to bring Maddie. So Maddie serves as one of the pediatric cystic fibrosis pharmacists at Intermountain Primary Children's Cystic Fibrosis Center in Salt Lake City, Utah, where she cares for patients in both inpatient and outpatient settings. Maddie received her doctorate of pharmacy degree from West Virginia University in 2020 and completed her PGY1 residency at Intermountain Primary Children's Hospital. After residency, she spent 2 years as a specialty and CF pharmacist at St. Luke's Cystic Fibrosis Center in Boise, Idaho, before transitioning to her current position. Her professional interests include patient education and transitions of care, medication access and adherence, and quality improvement.
Thanks. Good morning, everyone. So today I'll be presenting a case that occurred at my center on a premature infant who was exposed to elexacaftor, tezacaftor, ivacaftor, or ETI during pregnancy and then postnatally. I have no disclosures for this presentation. So today we're going to review this patient case, and then we'll dive into some pharmacokinetic factors related to ETI use in this during pregnancy and lactation population, and then analyze any evidence we have concerning safety and monitoring with ETI use during pregnancy and lactation, and describing what practice currently exists for postnatal care and diagnostic screening in infants born to these mothers who continue ETI use during pregnancy and lactation. So first, I wanted to provide a little bit of background about why this is so relevant for us to be discussing. And I know we've seen a lot of this information throughout the conference, but just wanted to highlight that before approval of ETI, we had pretty stable amounts of pregnancy for patients with cystic fibrosis from 2009 to 2019. Then we see the huge spike after ETI approval. On the right-hand side is an exciting graphic from the 2023 registry data that shows over the past 20 years the change in this population of 162 pregnancies in 2003 to 675 pregnancies in 2023. So, brief outline for today, we will first go through this patient case, and then we'll be going through a survey that was conducted by the CF Foundation Pharmacy Research Collaborative Group, or CF Pharm Group. And this is a newer group with the CF Foundation that's focused on advancing pharmacy-related research. And so in this specific survey, we were looking to explore what clinical practices are out there right now within centers regarding highly effective modulator therapy in pregnancy and postnatal care in this population. We also have our results on a poster 498 if you want to check that out. And so throughout this survey, we explore 4 main topics with exposure, monitoring, education, and communication amongst care team members. First, we'll start with our patient case. With this patient case, we have an adult patient with cystic fibrosis who is on ETI therapy and became pregnant. She enrolled in the Mayflower study, which I'll just take a brief second to overview here. It's a prospective multi-center study looking at maternal and fetal outcomes in the era of modulators. One exciting component of the study is the infant ETI pharmacokinetic sub-study that they'll evaluate ETI concentrations in cord blood, maternal blood, infant blood, and in breast milk in participants who are taking ETI throughout pregnancy and post-delivery. And this is the most up-to-date information I had when preparing these slides, but there was a Mayflowers update earlier in an earlier session, and they also have a poster at conference this year where they provided more of an update of where they're at now. For this family specifically, through shared decision-making, mother continued ETI use throughout pregnancy, which brings us to our patient, a premature infant born at 28 weeks and 6 days. This infant did have some complications related to prematurity, but in regards to their cystic fibrosis, they did have a normal newborn screen with an IRT of 40. However, due to known risk of mom with cystic fibrosis and dad being a carrier, we asked the newborn screen in Utah to run genetic tests on the first screen, and she tested positive for homozygous F508del variants. At this time, we didn't complete a sweat chloride test as she had a low birth weight, and we typically wait until they're greater than 2 kilograms to do the test, or until postmenstrual age of about 36 weeks. Otherwise, the test is often not sufficient quantity. So our patient continued to be exposed postnatally to ETI through breast milk that was administered via NG tube. During this time, we checked liver function tests, or LFTs, weekly, and they remained within normal limits. The patient was also routinely evaluated by ophthalmology to evaluate for retinopathy of prematurity, and they found no evidence of cataracts there. Looking a little bit more closely at pancreatic function, so on day 12 of life, we got our first fecal elastase measure at 91, which was indicative of pancreatic insufficiency. At this time, she was gaining weight appropriately and receiving only 20 milliliters of breast milk every 3 hours. And she also had an elevated bicarbonate level on her lab values, and we were limited on options about how we could administer enzymes at this time. One way that we could do this is by dissolving the enzymes in sodium bicarb and administering via NG tube. At this time, we elected to hold off on that because they did have an elevated bicarb and they were growing appropriately, so we didn't start enzymes at that time. We then repeated fecal elastase on day 30 of life, and we got a value of 130, which was surprising to us, indicating mild to moderate pancreatic insufficiency. She was receiving 32 milliliters of breast milk every 3 hours at this time, but we still elected to hold enzyme replacement therapy because she was still growing appropriately. And then on day 43 of life, weight gain plateaued, and we rechecked another fecal elastase. This time it was at 37. She was receiving 38 milliliters of breast milk every 3 hours, and at that point, we did initiate pancreatic enzymes dissolved in the sodium bicarb and administered via NG tube. So our patient was discharged from the neonatal ICU on day 112 of life. Breastfeeding was discontinued due to decreased supply. Since discharge, our patient has required a couple courses of antibiotics and a bronchoscopy was completed due to persistent atelectasis. She also required supplemental oxygen in the setting of bronchopulmonary dysplasia, but is now requiring less oxygen and is almost completely weaned off. So for any premature infant born at 28 weeks, feeding and growth can be a huge area of concern. However, throughout this time, she still continues to maintain excellent growth and nutritional status. And considering her complications with prematurity that she experienced, in addition to having her cystic fibrosis, it's really remarkable the positive outcome that she has had throughout this time. And so this kind of leads us to the question, did ETI exposure during pregnancy and postnatally contribute to her positive clinical outcomes? Next, we'll go into the survey portion. In this survey, we received a total of 100 responses across approximately 66 centers, primarily composed of physicians, advanced practice practitioners, and pharmacists. With this, we really sought to assess clinical practices related to highly effective modulator use during pregnancy and to infants exposed to therapy in utero or through lactation. So first, we'll start with the topic of exposure to ETI. We asked the question, if you have a patient with cystic fibrosis who is on a highly effective modulator and becomes pregnant, do you recommend that this patient continues that highly effective modulator throughout pregnancy and lactation? We had 77% of participants recommend that they would continue that modulator throughout pregnancy and lactation, which matches with the update in the Mayflower study that showed that they're seeing most moms are continuing their modulator therapy throughout pregnancy and lactation. So what do we know about this so far about published literature? We've seen a lot of preclinical data showing that all components of ETI are exposed in utero and then through breast milk. Here I've highlighted a couple of clinical series. One is a case series that shows that high concentrations of ETI were found in cord blood, suggesting placental transfer, and that concentrations were also found in breast milk in lower concentrations. In the next case report, they also found that ETI remained stable in breast milk and was detected in the child's plasma who was receiving the breast milk. Here, I've highlighted a couple of outcomes we have that are pretty exciting from use of modulators during pregnancy and lactation. The first is a survey conducted by Dr. Taylor Kauser with 45 pregnancies. And during this survey, they found no infant complications. They had 6 moms who discontinued ETI due to concern for unknown risk to the fetus. Of those 6, 5 of them had to reinitiate ETI due to clinical deterioration from discontinuation. The second one I wanted to highlight here is the case report by Dr. Fortner that was released in 2021 of an infant born to a mother who continued ETI therapy throughout pregnancy. The infant had a false negative newborn screen, normal pancreatic function, and lower than expected sweat chloride levels. And they also had a normal eye exam at 2 months of age. We also know some interesting reports and other cases that we've talked about at this conference as well about moms without cystic fibrosis who find that their baby has cystic fibrosis during pregnancy and start ETI therapy. The first one that I've highlighted here is a mom who initiated ETI at 32 weeks to treat her fetus with CF who had meconium ileus. The infant was delivered at 36 weeks with no complications, and they were pancreatic sufficient at age 2 weeks. Throughout that time, both mom and baby had normal liver enzyme levels. The next case report was, again, a mom without cystic fibrosis who initiated ETI at 31 weeks to treat her fetus with meconium ileus. And at birth, there were no signs of bowel obstruction. And so it looks like the signs of meconium ileus had resolved. They were with both mom and baby in this one too, they had normal liver function, and this patient was found to be pancreatic insufficient. But we know this doesn't come without risks as well. In the case series by Jane and colleagues, they found that three cases of pregnancies where infants were exposed to ETI in utero and while breastfeeding. They were found to have bilateral congenital cataracts within 6 months of birth. Of note, none of these had significant visual impairment. And then the second one, a newer study that went around and recently was on the listserv as well, looking at potential concern for if tezacaftor inhibits ceramide production in the brain, which could potentially impair myelin production, what impact could this have on neural development of infants who are exposed to ETI therapy in utero and through lactation? And this was just looking at a cellular model, and we really don't have any clinical evidence to show one way or the other. I did note that during the Mayflower update, they looked at developmental milestones within the patients that they're seeing with this preliminary data so far. And they're seeing that they're meeting a lot of the milestones that we would think that they would be meeting developmentally. So definitely an area to think about with these patients. So with these concerns, kind of thinking about risks potentially for these infants being exposed, what monitoring are we doing for these patients? And so that leads us to our next survey question. For these infants born to a mother who continued highly effective modulator therapy throughout pregnancy and or lactation, what do you recommend as far as monitoring for the infant? So most survey participants said yes, they do recommend some form of monitoring within the first 3 months of life. 76% said specifically they would recommend cataract monitoring, and 81% said that they would specifically recommend liver monitoring. And this would be for a baby with or without cystic fibrosis, as long as they were exposed to that highly effective modulator therapy throughout pregnancy and or lactation. And so thinking about why this might be important in this specific population as well, we all know that children are not just little tiny adults. We can't just think about size difference whenever we think about pediatric population. We also have to consider other developmental components, including the cytochrome P450 system that I've highlighted here. We know that the primary elimination pathway for all components of ETI is the CYP3A4 pathway, which isn't fully developed until patients are about 1 to 2 years old. And we know that this pathway does have another similar component to 3A4. Infants after birth have a higher concentration of CYP3A7, which is similar in structure to CYP3A4, but maybe isn't necessarily equal in all functional capacity to CYP3A4. And so with this difference in kind of their metabolic capacity potentially, what changes could that mean for how they're metabolizing ETI, if any? And we really just don't know this yet. We don't have enough data to show in this population how they're metabolizing this, or if their clearance and metabolic capacity is the same as what we would expect in an older patient. So next, shifting gears to how are we providing education for these patients? We asked the survey question of if centers have a process for providing education to people with cystic fibrosis who are taking highly effective modulator therapy when they discover that they're pregnant and who continue during lactation. Only 8% of centers said that they had a defined educational process regarding highly effective modulator therapy in these populations. Those who said they did have a defined process, that included something like a handout or a specific verbal criteria that they would kind of go through whenever they would talk with these patients. Many survey participants said that they have some educational process. It just might not be a formalized process that they use. Which brings us to another patient case that I threw in here on a patient that we consulted on, but wasn't necessarily our cystic fibrosis patient. For this patient, they were born to an adult cystic fibrosis patient who continued ETI and became pregnant. The infant was born outside of our state and had a negative newborn screen. So the way that we became aware of this patient was when they were admitted for failure to thrive. We checked a fecal elastase, they were pancreatic sufficient, and their sweat chloride levels were within normal limits. So now that this patient is discharged, they continued to be exposed to ETI. At least when they were discharged, they were continuing to breastfeed. And so that brings up a couple questions with this case. First, since that first sweat chloride was negative within normal limits, and that patient was still being exposed to ETI through breast milk, should a sweat test be repeated at some point? And if it should, when should it be repeated? Should it be after they're completely done breastfeeding or before? What point should we proceed with that? And then also, who's responsible for that follow-up? Is it a CF care team? Is it their pediatrician? Who's responsible for following up on that sweat chloride, but also who's responsible for following up on potential monitoring that we might want to do for that exposure to ETI therapy? That brings us to the next question on our survey for babies who do have a negative newborn screen for CF, like this baby, but were exposed to modulator therapy throughout pregnancy. Do you recommend that the baby completes a sweat test? The majority of survey participants said yes, they do recommend that the baby completes a sweat test. But if that first test is negative, like it was in this patient case, most recommend not repeating a sweat test. If they did say that they would repeat a sweat test, many recommend repeating at least 4 to 6 months after the negative test, or variable answers depending on if they're still breastfeeding. Some said wait and some duration of time after they're done with breastfeeding. Which brings us to communication. How are we communicating amongst all of these care teams? With this same sort of patient, a baby who has a negative newborn screen for cystic fibrosis was exposed to highly effective modulator therapy throughout pregnancy. Do you recommend communicating with their pediatrician regarding follow-up and rescreening recommendations? Only 50% of centers report having communication with these outside providers. So that leaves a lot of communication gaps that we're seeing here as far as follow-up monitoring and follow-up diagnostic screening for these patients. Our next question that we asked was for an infant born to a mother who continued highly effective modulator therapy. Who is responsible for following up? So we have a patient like this patient case who maybe needs some monitoring, maybe needs another diagnostic screen. But I wanted to ask the room by a show of hands, who do you think is responsible for following up for this patient? By show of hands, raise your hand if you think it is a non-CF pediatrician or non-CF provider that's responsible for that follow-up. Okay. And then by show of hands, who thinks it is a CF care team, whether that be the adult or pediatric team that's responsible for follow-up? Okay. Yeah, so it looks like the majority of people in this room think that it would be more of a CF care center team who would be responsible for this follow-up. In the survey, when we asked, it was pretty evenly split between the CF clinic team and a non-CF pediatrician. When we asked specifically which CF clinic team you think would be responsible for this, 7 participants said that the adult team solely should be responsible for this. 15 said the pediatric team should be responsible for this. And 22 said both the adult and pediatric team should be responsible for this. So that brings us to this lovely graphic that Sabrina Sherwood created that you may have seen earlier in this conference as well. But it really highlights that mom and baby family is in the center of this care model with the many moving pieces that might be around them. So that would include the CF care team, the pediatrician, their PCP, maternal fetal medicine, OBGYN, other moving pieces that are around there, that it can be very overwhelming for the family at this time when they have so many different providers to piece the information together that they might be receiving from all of these different providers and make decisions moving forward about the best care specifically for them. And so I think my biggest takeaway from the results of this survey is just really when we're thinking about this, we need to be focused on shared decision-making, partnering with mom, family, and what's best for the family, and keeping them, again, at the center of this. So key takeaways, again, there are significant gaps regarding what we're recommending for utilization, education, and coordinating of modulator use during pregnancy and postnatal care. There's also a lack of standardization as far as how we're monitoring for potential side effects and diagnostic screening for these infants exposed to highly effective modulator therapy during pregnancy and lactation. Also, how important it is to communicate with non-CF providers about modulator risks that could potentially be presented to these patients. And again, a lot of pediatricians might not necessarily be familiar with these medications. And so helping to bridge that gap in knowledge and making sure this isn't falling between the cracks for these patients. Again, importance of shared decision-making with the family. And finally, I think we all can see that there's a need for guidance to optimize maternal and infant health outcomes in the CF community. We've talked about it a lot at this conference and going to hear more about this topic during the plenary today. And I'm excited to kind of move forward with this. And I'm excited that we're talking about this topic, even though we may not have a lot of specific answers at this time. It's good that we're gathering all of this information and continuing to talk about it. And with that, I think maybe we'll do questions now. Okay.
Yep, so if speakers could come up here, we'll take some questions. If anyone in the room has a question and they want to step up to the mic, feel free. But I think we'll go through questions like that. So this is for Denise. Given CF and or diabetes, given that they can be risk factors for gastroparesis, are there any assessments or testing recommended before starting GLP-1 agonists to screen for gastroparesis at baseline?
So for our patients, So for patients with a history of gastroparesis, they're actually excluded from the pharmacist clinic for starting in the GLP-1 agonist for weight loss specifically. In the diabetes clinic, the endocrinologist will assess whether or not we could start it, but I don't think we've started it on patients with a history of gastroparesis for the reason that they're likely not going to tolerate the GLP-1 agonist. But with that said, for the patients who are starting the GLP-1 agonist, it does delay gastric emptying. There are some similar signs and symptoms for gastroparesis. So you would probably want to look out for worsening constipation and probably increasing their, you're going to want to increase their Miralax or any other sort of medications they're using for constipation. Specifically for gastroparesis, if they're experiencing the signs and symptoms like nausea and vomiting, it's really hard to tease out if that's from the GLP-1 agonist or from gastroparesis. So at that point, you would end up holding the therapy, or for the clinic, they may step down on the dose to back to something that they're tolerating to see if the signs and symptoms have improved or relieved. Did that answer the question, or?
There's another one for Denise. Has your team tried to use GLP-1s in patients without diabetes diagnosis, and any success or insights?
Yeah, so for our care model at Stanford, we have the endocrinologist that works closely with the CF team manage the patients who have diabetes on starting GLP-1 agonists, and we've mainly started it on those patients. For the patients who don't have an underlying diagnosis of diabetes, we usually go through the weight loss clinic, and for that patient population, we haven't started at Stanford yet, just given the concerns and risks for pancreatitis.
Here's one for Nicole. Have you ever been told by AFPs that they aren't able to communicate with Vertex? We've had to facilitate communication and provide exclusion letters, et cetera, for PAP considerations for certain AFPs.
Not necessarily. I haven't heard that. I don't directly work in the clinic, so I don't get to see a lot of the Vertex pieces of that. But so to answer, I believe that that is the case. Just knowing that AFPs are kind of sneaky in the way that they communicate to get free drug for patients. I would think that it causes a barrier between Vertex and AFPs in order to get patients medications.
Is the Accessia grants available for families in all states?
It is available, but however, one thing I didn't mention in my speech is that a lot of times these grants do close due to lack of funding. So currently, the Accessia grant is lacking funding, and it's not available currently.
And then do you have any suggestions on obtaining access for patients with AFP plans who are denied PAP and insurance refuses to pay after denial of PAP?
Great question. I have never seen denial after for them to change over to the maximizer type plan. So I'm not really aware after the denial of any patient not being able to get put back on the formulary.
Everyone at the mic.
First, Nicole, I want to say thank you so much for touching on the topic of AFPs. It's something that I have really been diving into over the course of the last year or so and have researched a lot on. And I just wanted to add a few more key points to what you brought up. So, like you said, AFPs, they are a for-profit third-party vendor, but they are not insurance. They are not the clearinghouse. And there's a lot of legal and regulatory risks that go with working with them through FDA, HIPAA, FTA, ACA, ERISA, and CAA. I understand you've had a lot of success with them, and that's great. Unfortunately, I think it's more so the case of they're denying and they're not getting access because, like you said, the methods that they use are kind of unethical and misrepresenting. AbbVie actually has lawsuit against Payer Matrix currently because of their practices. So the way they misrepresent them. So the one thing that I would recommend for patients, if they are getting denied by PAP through their AFP and insurance is still saying it, the important thing is to go up from the bottom. Go to the HR department. If the plan is accredited through, I forget what the accreditation bureau is for them. But if they have an accredited plan, they are required to provide those necessary, medically necessary and life-saving medications like Trikafta and other HEI and modulator therapies. And yeah, if anybody has questions about AFPs, come see me afterwards. I'm happy to share and thank you.
There's a few, but go ahead.
Jenna, let's chat. So did your patient get better getting 5 levels or whatever?
The biggest benefit is just the transparent, open communication that we feel like we've been able to build a stronger relationship and having these conversations and working through something that works for her. So,
Or were those admissions?
no.
I was curious because you said you were only doing them inpatient-ish. So it looked like she was admitted or was admitted every 2 months.
So we had 2 of her levels were outpatient.
Oh, good.
The others were inpatient. And so,
Okay.
yeah.
Maybe she's better. The reason I bring it up is I'm more of a sweat girl until proven otherwise so far. Because I've got to do levels twice now. And you're right. I did trough set first because that's what we're talking about on our listserv. And then I was like, one was completely undetectable for all 3. Well, that was very unhelpful. So if anybody's getting to the point of boosting, because again, these patients swear they're adherent, their NPR is perfect. We ended up getting a peak with some detectable levels, but still not at this goal that we may be boosting here shortly. Even though I still probably feel it's more social. But I did want to just say like sweats can also maybe be considered instead of this because I feel like we just have a lot more luck with that, I guess. Well, plus it's internal, but it seems to just correlate better than these wonky levels that we're all getting at this point. And I'm not quite sure it's benefiting us.
We got, there was a point where it was like the 18-day delay or whatever. It was taking a while to get the levels back. And so we were just trying to get to the bottom of what was going on in that specific situation. And we did re-sweat her and her at diagnosis was 90, and then on that sweat was 54. And so she was
needs
seeing
better.
benefit, and we got the result much faster. So I think pairing the two,
Right.
as we're learning, yeah. But I'm glad you mentioned that. Yeah.
Well, and the last thing I'll say, sorry, I don't want to be the commenter all the time, but I think if anybody from Paul Behringer's lab here, our work, the EC50, I think we also need to pay attention to that. Do we really need to reach these targets based on sweats, right? I think is something to consider, because if we're getting the same effect at EC50 versus I think are these the 90, that we probably don't need to get to a goal if the sweat's normal. Yeah.
Here's another one for Jenna. What costs have patients seen for ETI levels? Are these typically covered by insurance?
That's a great question. So partially because the way we've implemented this workflow, it's a part of the admission. So it's going to be a part of that admission cost bundle reimbursement. So we have not encountered any challenges yet with reimbursement for that reason, but also for those that are outpatient. We've primarily only done this in Medicaid patients at this point. In reviewing the National Jewish website, they've got some general outlines of like how much they're charging for things. It doesn't specifically say TRIKAFTA levels, but there's a range of like $29 to $140 for how much they are billing. And then there's transparency with all sorts of hospital costs. I haven't been able to find that at Texas Children's specifically for this patient. So we have, I guess to answer your question, we have not come across that as a barrier yet. However, prior to utilizing this for a commercial patient, it's something that I need to get to want to get clarity on, and we'll be happy to share with the listserv. So
I have one for Maddie. In your patient case, did you consider pursuing off-label ETI?
We did not consider that for this patient. Yeah. I know that's been something that we've talked about during this conference too, about potentially dose spacing based on granules and patient size. But no, we didn't consider that for this patient.
Few more at Jenna, with your current process, are patients aware that that an ETI level is being drawn? And if so, are they open or receptive to them?
yes, so we make patients aware prior, I think the current culture and systems require that we notify patients before we do really anything and have those conversations. So we did, especially this patient, we made them aware prior to obtaining those levels. And we didn't receive any opposition with that because the patient at this age, they're also aware of, they do have some understanding of medications and how they can be individualized. Medicine can be individualized, doses can be individualized for patients. And so I think just that general understanding, they were open to it. So we haven't come across that yet, but I am curious to see if others have had any opposition with getting TRIKAFTA level monitoring, any challenges.
What tips do you have for approaching a conversation with a patient after the drug monitoring has demonstrated non-adherence despite the patient?
Sure, yeah. So I'm honestly just utilizing the same kind of tools that you would use, approach you would use in having a conversation when you've identified that they haven't refilled their medications timely and that there's a gap. And even though they're saying they refilled it last month, they didn't refill last month, but just approaching it in a not a shame-free way, just approaching it as objective. This is the information we're seeing. And it's, I think it's very important to keep that rapport, that they do not feel guilt or shame by any means, and just having an open conversation. This is what the information is. Can you help us understand why this may be the case? And that's really what has led to them feeling more open about it. So, yeah.
You're the hot topic. This is the last question in the app, so if anybody has any other questions, wants to add more or come up to the mic. But have you considered measuring levels to help ensure efficacy when dose adjustments are made related to side effects?
100%. And that's probably the area where we're using the levels, or we're trying to incorporate the levels even more for our patients that are on modified doses. Yes, I agree with the utility of that in practice. And now that we know that there's a strong correlation between troughs and AUC, I think that that's going to be, that's even more telling. We will be adapting our process to account for that, but we have a significant number of patients on modified dosing, and I support considering at your centers how you can incorporate this to evaluate that and correlate it. And I think it's going to be because of the variability in the levels. So my patients' levels that I showed were, hers were like 1 to 2 for a lot of the things, versus we've had others that'll be closer to those National Jewish defined levels. So I think you need to identify what your patient's specific range is. You're going to have to trend. I would recommend trending. We'll need multiple levels to be able to understand your patient's specific trend and following as you make dose adjustments. So how we've incorporated that for dose titrations is prior to, for those that have had side effects and we're reinitiating it and titrating it up, we do get a level before we do the next dose titration. I hope that was helpful. Happy to share more.
I have one. For Maddie, yeah. What do you see as the CF Farm's next step following the survey? And how can pharmacists get involved?
Yeah. So I know the CF Farm Group is actively recruiting pharmacists who want to join. So I know Sabrina, you can message her specifically about the reproductive health subgroup. And
Yeah, I had respect.
mhm. Yeah, so big moves in the CF Farm research group. And then as far as next steps moving forward with this specific area, I think one thing that we want to do is kind of collect different case series and case reports and instances of this happening and bring them together and talk more about what's actually happening in practice and go from there with what information that shows. And then I know there's a bunch of other brainstorming that's been going on with the group, so more to come.
Well, I think this concludes this session. We'll give you 15 minutes back of your day. If you have any questions, you can email any of the speakers or your chairs. Happy to answer what we can. Thank you, guys. Thank you.